This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to Apple Podcasts and give us a ratings and review. That way more people can find out about the Rational Wellness Podcast. Also, you can go to the YouTube page and there's a video version there. And if you go to my website, drweitz.com, you can get complete show notes and a full transcript. Our topic for today is inflammatory bowel disorders, of which Crohn's disease and ulcerative colitis are the most common conditions. There are also a few less common inflammatory bowel conditions, including microscopic colitis, which can only be identified upon biopsy of the intestinal wall. Inflammatory bowel disease is characterized by chronic inflammation of the gastrointestinal tract that leads to damage to the mucosal lining of this digestive tract. Crohn's disease can affect any part of the GI tract, including the mouth, esophagus, stomach, and the anus, but it most often affects the portion of the small intestine closest to the large intestine, and there tends to be patchy areas of damage, and the damage may reach through multiple layers of the intestinal wall. Ulcerative colitis occurs only in the large intestine and the rectum. Damaged areas tend to be continuous and usually start at the rectum and spread into the colon, and is usually present only in the innermost lining of the colon. Symptoms of inflammatory bowel disorders include persistent diarrhea, abdominal pain and cramping, bloody stools, weight loss, fatigue, among others. Anemia and other nutritional deficiencies are common. The mainstays of conventional medical treatment include immunosuppressive drugs like prednisone and biologics like Humira and Remicade, and surgical resection in severe cases. Dr. Ilana Gurevich is a board-certified naturopathic physician and acupuncturist, and is currently co-owner of two large integrative medical clinics, one in Northwest Portland and one in Northeast Portland. She runs a very busy private practice specializing in treating inflammatory bowel disease, as well as IBS, SIBO, and functional GI disorders. She lectures extensively and teaches about both conventional and natural treatments for inflammatory bowel disease, as well as SIBO. Dr. Gurevich, thank you so much for joining me.
Thank you so much for having me.
Excellent. So when you get a patient in your office, what makes you suspect them as having inflammatory bowel disorder?
So at this point, my practice is really, really specialized. So I'm only seeing GI-based disorders. Okay. And there's a certain subset of symptoms. And when you rule out, if they're having frank blood, if they're having extensive pain, if they're having nutritional deficiencies, anemia is one of the most common things I see. If they're cachexic, well below a normal healthy weight, then you're always thinking inflammatory bowel disease. It can sometimes present with constipation, but that's much more rare. And then, the other thing you're generally looking at with ulcerative colitis, you're looking for bleeding. Ulcerative colitis patients have, depending on their severity, somewhere between 5 and 30 bowel movements a day. A lot of those bowel movements are just blood or blood and mucus. Crohn's disease presents significantly more with pain, really intense acute abdominal pain. And Crohn's disease patients are at risk for obstructions, which is basically an acute abdomen that can present really out of nowhere. And all of a sudden they have, 14 out of 10 pain, and they have to be hospitalized, and then they have to go in for emergency surgery to resect.
So what happens when they get that obstruction?
Generally speaking, the only way to get you out of a complete obstruction is to surgically remove that part of the obstruction. If it's a harsh,
So what exactly is happening anatomically in that case?
So 80% of of Crohn's disease patients have some kind of terminal ileum involvement. The terminal ileum is the bottom of the intestine, and the ileocecal valve is right there. That part can often, Crohn's disease, what happens with it is you get this shrinking or narrowing of the lumen, and eventually that narrowing gets so small that it's completely obstructed. That then is the surgical emergency. There are lots of Crohn's patients that are living with partial obstructions, where all of a sudden they eat just a little bit too much, or they eat something that they're not supposed to, and they get into this acute abdominal pain. They start vomiting because the body, you can't push it through the intestinal tract, so it comes back up. And then it kind of passes and they slow down their eating, and then they can kind of live this not very full life where, food is really well controlled, or has to be really specifically controlled not to flare. They can also develop strictures. Strictures are these little pieces of narrowing or thinning of the intestinal lumen, and that also leads to an obstruction. And a stricture, where partial obstructions can sometimes be inflammatory tissue, it can also sometimes be scar tissue, and strictures are much more commonly to be scar tissue. So biologic agents or steroids don't always work to respond to these strictures to decrease the narrowing. And so for a lot of these patients, surgery is really, they're just on a surgery track.
Wow. So how do you work these patients up?
So the thing about inflammatory bowel disease is the GI is a really, really complicated organ, and it controls, we know that the majority of your neurotransmitters in your brain are actually made in your intestinal lumen. So hormones play a part. We know that if you have food poisoning, that actually upregulates the likelihood of developing inflammatory bowel disease. We know that if you take antibiotics, within 6 months, you have a significantly higher likelihood of developing Crohn's disease. We know that parasites and protozoa can trigger these kind of inflammatory responses. They can also sometimes be treatment for these inflammatory responses, but sometimes they can trigger these diseases. Anything that you put into your GI tract, so pesticides, food coloring, preservatives, processed food that your body doesn't react to, can cause this subacute or acute inflammatory reaction, which then puts them on a track for inflammatory bowel disease. And the likelihood of developing inflammatory bowel disease is actually on the up. We see an increase in Western cultures. We see a huge increase in cultures that never had inflammatory bowel disease that are taking up a Western diet and lifestyle. And then we see increasing amounts in just like heavily medicated populations.
Another aspect of the benefits of spreading American culture around the world.
Lucky us. Yep.
So what kind of testing do you do for these patients? Colonoscopy and endoscopy, of course, right?
So that's the gold standard. When a patient comes in to see me, and if they haven't been diagnosed, one of the first things I'll do is stool fecal calprotectin. This is a stool collection that's looking for the amount of white blood cells or neutrophils that are localized within the intestine. It is very, very, very predictive for ulcerative colitis, almost 98% predictive for ulcerative colitis. It is somewhere between 30 and 90% predictive for Crohn's disease. I think that is partially because a lot of Crohn's patients don't have any disease in their large intestine. They're really just localized to their small bowel or upper GI. Those patients are not going to be great testing subjects for calprotectin. Lactoferrin is another test that we can do. You can also look at, for Crohn's disease, you can look at inflammatory markers like a sedge rate or a HSC, high specific CRP, or also a regular CRP. The literature is a little bit mixed about which one is a better test for IBD. And then once you have a diagnosis,
by the way, on a fecal calprotectin, what's the cutoff value?
So 50 or under is negative. If you're between 50 and 120, you're considered borderline, and then you're supposed to retest in 6 weeks. If you're over that, then you're considered positive. And depending on how high over that you are, that's how significant the inflammation is, with the exception of ulcerative proctitis. Ulcerative proctitis is an ulcerative colitis that is only at the bottom part of the intestinal tract. And those patients just have really, really high calprotectins because all of the white blood cells are right there. We're collecting the stool that's right there. So you'll often see calprotectins for these patients in the thousands. And that doesn't necessarily talk about severity of their disease. It just talks about location and the fact that we can find them really easily.
Okay.
And then my other favorite test right now, actually for monitoring for Crohn's disease patients, is Prometheus Labs has recently come out with something called a Crohn's monitor score, which is a blood test, which anybody who treats IBD, patients complain about the fact that they have to collect their poop, which is gross, and then carry their poop in their purse, which is gross, to drop it off at the lab. This is a blood test. They don't have to be fasting. It takes 13 separate biomarkers, and it's actually considered, I think it's 92% specific, 98% sensitive for Crohn's disease, which is, that's better than a calprotectin.
Yeah, cool.
Yeah. And so that's what I've been using now for monitoring.
So Prometheus Labs.
Mm-hmm. And they're the ones, all IBD patients know them because they're the ones who have the Crohn's blood test to differentiate Crohn's and ulcerative colitis. They're also the ones that have the blood test that looks at biologic levels to see if you're within, ranges, if the drug is working effectively. And so they're a standard lab. And so that is generally my standard workup. My functional medicine or naturopathic workup includes stool testing for protozoa and parasites. I'm using DNA stool testing now. It's stool testing for inflammatory markers in the small bowel. Zonulin is one that I use a lot, even though I think the literature is a little bit mixed on it. I'm also sometimes looking at food allergies and food intolerances. Not always, but sometimes. And then what else is in my workup? And then nutrients.
For the stool test, I think I heard you say that you're using GI map now.
That's my favorite right now. I think that the DNA PCR is like a game changer, actually.
Right. Cool. So how do you apply a functional medicine approach to these patients?
I think it all comes down to the history. These people, they were not born with inflammatory bowel disease. Something happened to have them develop it. And so you're kind of figuring out when they started feeling bad, how long they felt bad, how many workups did they go through. And then based on that, you're coming up with, okay, I think that this is a really hormonally mediated inflammatory bowel disease. So we're going to really focus on the hormones. Or, this is a clear cut. You were over medicated. You took too many antibiotics. This is clearly a microbiome disorder. And so we have to focus on that. Or, a lot of patients, stress is one of the things that could definitely trigger one of these acute attacks. And so, how are they mitigating their stress? Like I have patients time and again who are so well controlled. I'm running calprotectin on them every 3 months. I'm running Crohn's monitor every 3 months. They're so well controlled. And then all of a sudden a stressful event hits and we lose control. So those people were all talking about the lifestyle. Are they getting counseling? How are they dealing with their stress triggers? And so every patient is kind of their own individual, and you have to figure out why this person has inflammatory bowel disease.
Right. I heard you speak with Dr. Narella Jacoby on her podcast last year, and you mentioned that you will often see a scarred and or open ileocecal valve, and that this can play a role in increasing their symptoms by increasing the risk of SIBO in these patients. And I spoke to Dr. Pimentel a few months ago, and he did not feel like the ileocecal valve plays much of a role in IBS patients. He really focuses on motility as the key cause of SIBO. And when I was talking to him, he said that even patients who have had their ileocecal valve removed, do not necessarily have SIBO as long as they have good intestinal motility.
So I've spoken to Dr. Pimentel a lot. I really respect the work that he did. I feel like, if his theory on bacterial overgrowth holds true, it's like a game changer. However, I feel like a lot of his research is really structured on the fact that he is trying to differentiate IBS from IBD. If you look at all of his stats and all of his slides, he's basically like, we see this in IBD people and we don't see this in IBS people. But we see this in IBS people and we don't see this in IBD people. And I have to tell you, from what I've read in the literature, I just don't think that holds up. I think that what I'm seeing now, so there was this one study in 2009 that really, really old study before I think Pimentel even started teaching, I think he was publishing a little bit then, talks about how IBS is often one of these missed underlying causes in IBD. And I see this all of the time where you see these people and you're like, okay, you're clearly in a flare, you're in a lot of pain, you're having diarrhea, let's double your biologic, let's triple, okay, let's switch your biologic, okay, let's add a steroid, let's add budesonide, and they're not getting any relief. And then you figure out exactly you work them up for IBS, you find the IBS, you treat the IBS.
You do like a breath test?
Exactly. You do a breath test and and you treat it and they completely go into remission. I have this one patient who completely changed I lecture about her all the time. She changed my entire trajectory of understanding Crohn's disease. She came in, she saw me, she was 42 years old, and she had a BMI of 16. She was completely amenorrheic for over 7 years because she was so cachexic. She had such terrible inflammation in the leg, she would wear stockings, compression stockings to keep it in. And I just happened to sit through one of Alison Seebecker's, the first lecture Alison ever gave. I just attended the conference. And I was like, okay, let's work you up for this. She had been in a constant flare for, I think, 13 years. She refused any medication. She was like health guru, but so refused any medications, but could not get out of her flare. She was getting transfusions. She was so anemic. She was getting transfusions every 3 to 4 months because she was bleeding so heavily with the Crohn's disease. We treated her SIBO. She has been in remission for over 6 years. And she had no ileocecal valve. I continue to treat her SIBO. She's on rotating herbs on a regular basis. That is the main reason why she's in remission. There is no way that you can pretend that IBS and IBD have nothing in common.
Well, if you think about it, Dr. Pimentel's idea that IBS is really an autoimmune disease actually fits nicely with this and makes it even more likely that IBS is related to IBD.
1,000%. Yeah. I mean, and so the thing, Crohn's patients, 80% of them have some kind of involvement in their terminal ileum, right? Which basically means if you have scarring or sclerosis of that part of your intestine, motility is going to be affected. There is no way, functionally, that ileocecal valve is supposed to be a one-way, everything dumps, and back pressure has it close up. These people who have a scarred or inflamed terminal ileum and ileocecal valve, you're getting a ton of regurg. That is large bowel. Pimentel himself cites 10 to the third bacteria in the small bowel, 10 to the 12th bacteria in the large bowel. It is regurging right up into the small intestine. And then it's like the wild, wild west. There's all of this room. Everybody's bringing their family. Everybody's reproducing. Of course you get bacterial overgrowth. And then that bacterial overgrowth, of course, causes inflammation within the lumen. Of course.
Right. And I also heard you say that sometimes you use naturopathic manual therapy techniques.
So that is sometimes can be really, really helpful. I'd say less for inflammatory bowel disease patients because of the scarring.
Right.
The scarring is, so in the studies, there's only one study, I feel like, and it was a teeny tiny study that said that it can turn over strictures, which is using N-acetylglucosamine. I don't know if that's played out for me in my clinical practice. But I have that one study, so I try it on all my stricture patients. I use a lot of ozone for my inflammatory bowel disease patients, which I think it's the best treatment that I have. It's very uncomfortable, but it's a really effective treatment. But even that sometimes is intensive strictures. But, I think the goal is treat them aggressively so they never develop the strictures. But sometimes once they do, surgery is the only option.
What about those techniques for using manual massage type techniques for breaking up scars in intestines?
So the clear passage stuff, is that what you're thinking about?
Yeah.
They work on, and I send to them a lot, they are incredible at adhesions. So scar tissue that forms from the outside. They do not have, I think they themselves will not say, and I personally have not seen them do great with strictures. And I think it's just different mechanism of action. A stricture, it's inside the lumen. And so you have more localized, there's more of an inflammatory cascade there. And so because of that, using manual therapy to break up adhesions is not going to work because that's not the underlying cause.
Right.
But I will say, one of the things that I do have my patients do all of the time post-surgery is go to clear passage to get the adhesion work done, because the adhesion's predisposed to a second surgery for a different underlying cause. Okay. And so, inflammatory bowel disease patients will constantly go, I think they have on average somewhere between 2 and 5 years before they're expected to have a follow-up surgery.
Wow.
And so if you use the clear passage does have the studies to show that their manual work decreases the likelihood of repeat surgeries because they're cleaning up the adhesions.
I've really been enjoying this discussion, but I'd like to pause for a minute to tell you about our sponsor for this podcast. I'm proud that this episode of the Rational Wellness Podcast is sponsored by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help our patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative. This is a great resource for education for practitioners. I'm a subscriber to TAP Integrative. There's videos, there's lots of great information constantly being updated and improved upon by Dr. Lee Salschuler, who runs it. One of the things I really enjoy about TAP Integrative is that it includes a service that provides you with full copies of journal articles, and it's included in the yearly annual fee. And if you use the discount code WEITZ, WEITZ, you'll be able to subscribe for only $99 for the year. And now, back to our discussion. So what are the most common, besides SIBO, what are the most common co-infections that you'll see with your IBD patients? I saw an article by Jill Carnahan where she talked about parasites, candida, and also Epstein-Barr virus.
So I definitely see parasites and protozoa. Parasites are definitively, this is bad. Protozoa is often labeled as commensal. I really can't believe that. As a rule, I think that protozoa should not be within the system. And there was a really interesting IBS study in 2014 that looked at protozoa being the underlying cause for a lot of IBS-like symptoms.
Well, there are some people claiming that parasites should be part of our system too, and even using worm therapy.
So I mentioned that earlier, helminths are really interesting.
Yeah.
The problem with helminths and IBD is it takes 6 months for them to become effective.
Okay.
And so if they're in the middle of a flare, you've got 6 months, and the likelihood that you can make it through 6 months without A, obstructing, and B, ending up on some kind of immunosuppressant modality, you have to have a willpower of like a bull to be able to make it through. But helminths are really, really, really interesting. And protozoa, I don't think I would use parasites as. I think there are good worms. I think there are bad worms. I think, good worms don't reproduce within us. We can kind of help them shift the microbiome and the environment. Bad worms reproduce very aggressively and in and of themselves cause obstructions.
Right. Okay. So what are your favorite options for when patients have acute flares?
So diet is always key for what I do. If they're willing to do a specific carbohydrate diet, I think that's the best studied. There's also this other diet called semi-vegetarian Crohn's diet, which is basically exactly the opposite of SCD. SCD is really meat heavy, very paleo, no grains. The semi-vegetarian Crohn's diet is like a macrobiotic, really grain heavy, no meat like diet. Huh. And that one's been studied, I think, mainly in Korea. So if they are willing to give me a diet, I want them to give me a diet. At this point in my practice, ozone is my go-to. Ozone rectally is amazing. It's super uncomfortable. The theory of ozone, the reason why I find it so effective, or what I do in my practice is I'll start by either running a Crohn's monitor or a calprotectin before we start any kind of treatment, because I want a baseline, and then as soon as we get that results, we'll start treatment. When I start with ozone basically it's you take oxygen through an oxygen tank and you put it through an ozone generator, and it uses electricity to break up those very stable bonds. And so what happens with those bonds is we know about 20% of them reform in the ozone or O3, which is super, super, super unstable. In fact, if you leave that ozone in a bag, at the end of 30 minutes, it's going to be all oxygen because all of those third electrons are going to find each other. If you administer it rectally, what happens is because they're in an acute flare, they're having all this chronic inflammatory cascade. And so what's happening is they have all these reactive oxygen species, or O1s, that are just looking to unbreak their bonds, and that's causing the inflammation. So if you encephalate rectally ozone, that O3 finds those reactive oxygen species, and just like that, immediately, it's an anti-inflammatory. It works really, really quickly. It is very, very safe. However, it is so uncomfortable. It's really a borderline torture. Maybe that's extreme, but so, the large intestine, it's supposed to squeeze and push things out. And I am having them put in 750 cc's of gas up. And so what they get is bloating, obviously, cramping. Oftentimes they'll have intense bowel movements because the large intestine is getting the receptor, the information to stretch, which is making it purge. It will make it will at 750 cc's, which is what I use for Crohn's patients, they are burping up ozone. It is literally going up their entire GI system. Wow. Which means for the rest of that day, they are feeling gassy, bloated, distended, crampy. I mean, it's not comfortable. I don't use this treatment for my IBS people, but IBD, if I can give them this ozone, which we know rectally is 100% safe, and we know that because they recently did an animal study, not a human study, but an animal study. If I can give them that instead of steroid or a biologic, for me, it's a no-brainer. And it doesn't work across the board, but I'm going to say 70% of my population, I can get into a remission with it.
What about elemental diet?
Elemental diet, see, it's always a trick for me. What is more torturous? Putting a bunch of gas up your butt and getting bloated and distended, or drinking, or drinking this, this drink tastes great, day 1, minute 1, day 7, minute God knows what, it's borderline torture. But if they're not willing to do the gas, I'll totally go elemental diet. Glutamine has the potential to be really, really effective. The doses for glutamine is about 27 grams. Right. That's 9 grams 3 times a day for somebody who's my build. So that's a really high dose. Glutamine does not dissolve very well in water. It doesn't taste bad, but some people consider that torture. Some people get really good efficacy from it. Saccharomyces boulardii has really good potential to get people into remission. For ulcerative colitis, there's lots of good studies on the mixed probiotics. They used to study VSL3. Now that product is remarketed as Visbiome. But that is another really, for UC, that's something that I always try. Vitamin E rectally. For ulcerative,
Interesting.
And they have studies on it actually. For ulcerative proctitis, vitamin E is generally, honestly, for ulcerative proctitis patients, I'll start there. You use it now brand has this 54,600 IU per dose of vitamin E. It's got no fillers, no carrier oils.
Are you talking about D alpha or mixed tocopherols?
I think it's DL. I think it's DL. I think.
D alpha. Okay.
Yeah. You encephalate rectally at bedtime, like a retention enema, about 6 cc's.
Oh, so it comes in an enema, or
no? It comes in just it's like $15 a bottle. It just comes.
It's just a liquid. Okay.
Yeah, and you give patients syringes, and if they want Rexall catheters, I can give them that too. But that's where I'll usually start with ulcerative proctitis patients. If I work them up and it looks like they have a microbiome, inflammatory-based ulcerative proctitis.
What about curcumin, which is the original TNF alpha blocker?
So I'm using turmeric instead of curcumin, mainly because did you read that study? It was actually done with it was this Indian PhD who was the guy who originally did all the curcumin research. He turned around and he repeated his research 20 years later using curcumin-free turmeric because the curcumin market got so large. So India was sitting with all of this curcumin-free turmeric.
What to do with it?
Totally. And he was like, let me study it. And it was as efficacious. And so and it's cheaper. So yes, I totally use turmeric. I use turmeric more. I'll use it sometimes acutely. I've never seen it alone get somebody out of a flare, but I'll use it as my, this is what you're on indefinitely so you don't flare again protocol.
Right. I've seen mastic gum and then there's this herb that I've seen mentioned called thunder god vine.
I've never heard of that. There is a really interesting study on wormwood, on artemisia, keeping IBD. I have a couple of bad track records with using artemisia and getting really high LFTs, which, once you discontinue, the liver function test resolve.
Right.
Okay. I'm a little bit weary.
Okay. Can you talk about the use of biologics and some of the risks associated with taking them and coming off them?
Yes, actually, I feel like this is a little bit of my soapbox. So, biologics are really serious medications. They are immunosuppressants, so they really dull the immune system. Dulling the immune system then theoretically dulls the response of the neutrophils and lymphocytes that are attacking the lumen of the patients. And actually, the way that helmets work is by giving the immune system something else to attack so that it's not attacking itself.
Right.
So biologics, especially with peds, but even with adults, I'm very slow to start somebody on a biologic. I'm fortunate enough to work and live in Portland, Oregon, where I have a good gastro group that I refer to, that refers to me. And so they feel a little bit sometimes more comfortable holding off on the biologics. Some patients find me because they don't want to be on biologics. They have a lot of serious side effects. About 1 in 1,000 people will end up with some kind of lymphoma or cancer, higher likelihood of infections, and sometimes they don't work. However, and this is where my soapbox kicks in.
And that's because these biologics basically are blocking part of the immune system.
And in the past, with Crohn's disease patients...
And we're talking about drugs like Humira and Remicade, and there's a whole series of them.
So Humira, Remicade, and Cimzia are all TNF-alpha inhibitors. So that's where curcumin works on that. There's 2 new ones that are out, which is Entyvio and Stelara. Entyvio is large bowel only, and Stelara just came out. It's a new one for Crohn's. They are all... monoleukocyte inhibitors, I think. So, which is exciting because in the past we had one mechanism of action. If you didn't respond, you're done. Like they would try you on those 3 drugs in that order, and then you're done. Now we have these 2 other drugs. I think Entyvio, 40% efficacy of bringing you into remission. So not great stats, but if it works, it works. But the most important thing is these drugs are biologic mimickers, right? They mimic the biology of the system, which means that 1, your immune system might form a reaction to them. And 2, if you take them out of the system and the person goes into a flare, there is a significantly higher likelihood that when you put it back into the system, they're going to form a reaction to that drug. And then this really, really great tool that was working to keep the people out of a flare and keep them in remission is now no longer an option. And a lot of the other drug classes, the other drugs in the same class that are slightly different, might also not be an option. So, if a patient comes in and is well controlled and doesn't have side effects on a biologic, it's not going to be my advice to get off the biologic.
Yeah, I've had patients come in and every time they take their biologic, they got such a severe skin breakout that they had to take prednisone just to take the biologic.
Yeah, absolutely. And by no means is a biologic a perfect treatment for inflammatory bowel disease. But if it is a perfect treatment, and you're in a total remission, I am hard pressed to say you need to come off this biologic. I am going to give you everything we can to decrease likelihood of developing a lot of these lymphomas. Other ways to mitigate the immune system, get them on a clean diet, try to clean up their exposures, and do everything else in my field of ability. But I am going to be hard pressed to say, God, you've been controlled. Why would I stop that? Because this disease is terrible.
So why is it that they're more likely to react to the biologic if they stop it and bring it back?
Because now the immune system, which was suppressed, is unsuppressed and so revving. And as the biologic is fading out of their system, the immune system can tack onto that protein and then upregulate the immune response. So when they see it again, they're much more likely to form a reaction.
I see. Interesting.
And there's this really, so one of the ways that we use biologics, or not the standard medical community uses biologics, is they'll match it with immunosuppressants. So back when I was diagnosed, 25 years ago, we had 3 drugs that I could choose from. We had prednisone, we had mesalamine, and then we had 6-MP, which is also called Imuron. or azathioprine. They're all the same drug class. And so it has been, the studies have proven out over the last 20 years that those drugs are actually not very effective for treating inflammatory bowel disease. But what they will do is they will use combination therapy. So they'll start somebody on a biologic and then also start them on immunosuppressant to decrease the immune system even more from forming a reaction against the biologics. And I mean, biologics are not good. Immunosuppressants are awful. Like liver inflammation, liver swelling, infections, cancers, they're awful. And so these patients will get started on double treatment and then nobody takes them off. And so when I was putting together this large, my very long presentation for Neurology Jacoby's masterclass on IBD, and I was just looking through the literature on what studies have they looked at how long somebody should be on these immunosuppressants and how effective they are. And what the literature, and of course, nobody's done big studies on them. They're a little bit smaller studies. But what the literature has panned out is it is only effective if you do Remicade, if you do Humira, because Remicade is 75% human mimicker, 25% mouse genes. Humira is 100% human mimicker. And so if you give Remicade, because of those mouse genes, you're much more likely to form a reaction, obviously, because the body's much more likely to react to a mouse protein. And after 6 months, it has no efficacy. And the studies that they did about
you
side
have to
effects.
restrict cheese intake in that case?
You do.
I'm just kidding.
I mean, sometimes you do for other reasons.
The mouse of cheese. Yeah. Okay.
But
sorry.
The side effect profiles, the way they did the studies is they did biologic followed by immunosuppressant, or biologic and immunosuppressant together, and they did it over 2 years. And so the side effect profiles appeared almost identical because everybody got the immunosuppressant. And so generally if I'm going to counsel if they can, they're okay with injections. Humira is a better option. And I don't counsel to do immunosuppressants usually.
Okay. Now, you mentioned with respect to diet, food sensitivities. Mm-hmm. How do you sort through that? And are there certain, you mentioned 2 completely different types of diets, paleo type of diet, which restricts grains and legumes and things like that. And then you also mentioned more of a vegetarian type of diet.
So what I use in my practice is called the Carroll Food Intolerance Test. Okay. Which nobody has heard about unless they're a naturopath who graduated from one of the West Coast schools. It is this really, really kooky, energetic-based diet that's Dr. Carroll created it in the 1920s. We do it in basically the same ways. For me, I think there's no studies on it. There's no science on it. But for me, clinically, it's one of the ways that I've been able to keep my disease in remission. And I feel like it's kind of often the most accurate. I don't use any of the IgG. I don't use any of those tests. I find that those in my clinical practice are futile. My entire population has intestinal permeability. They have intestinal permeability because they're seeking out my treatment and waiting to get in it with me for an appointment, right? So that test is just going to do a good job really telling me what they're eating. So I don't use that test at all. I think elimination is probably the gold standard. And so, what I'll do is I'll start them on SCD if they're okay with meat. I think it's better studied. If I can get them into remission, great. If I can't, or if they hate meat, I'll start them with the other one. I'll flip.
Have you used low FODMAP?
I feel, yes, definitely. And I feel like what I'll do is I'll put them on any diet. I'll put them on a restricted diet, either SCD, whatever they want to start with, until they're able to get into control. And then once they've been in control for a little while, I like them to, it's not sustainable to do that diet for the rest of your life. I call that diet a skeleton. And then we want to put the meat and the muscle on the skeleton. Introduce, challenge. Did you do okay? Great. Introduce, challenge. Did you do okay? No? Okay, stop. Go back to where you just ended. Let's give it a couple of days. Okay, now you're ready. Introduce, challenge. I want them to figure out what they can eat and what they can't eat.
So if you do an elimination diet, how many foods do you eliminate?
All of the main intolerances. So dairy, gluten, eggs that are not organic, soy, corn, nightshades, sugar, So like the standard anti-inflammatory diet.
How often do you find that gluten and dairy need to be kept out?
So not as much as I would have expected.
Okay.
Not as much. I feel like people who react know right away. So not as much as I would expect.
Okay. How often do you find heavy metals or mold as cofactors?
I think I am probably under-treating and under-testing, because there is this entire theory about fungus being one of the big underlying causes of Crohn's disease.
Right.
And I think that I'm not paying enough attention to it, if we're honest.
Right. Well, it's a lot of stuff to pay attention to.
Yeah, it's true.
Okay. So I think those are the main questions I had. I thought that was a good interview.
Thank you. You are also extraordinarily well-researched. I've been listening to a lot of your podcasts.
Oh, you have?
I don't. Yeah, you are like extraordinarily well-researced.
Well,
I don't know how you find time to do it.
I just don't sleep.
Oh, great. That's healthy. Totally no side effects to that.
Exactly. So how can our viewers get a hold of you and find out about your programs? I know you have this IBD course, right? That's available through Neurala.
Yep. So it's SIBO Doctor Master Course through Neurologic OB. I think you Google that. So that is going to be, I do my final interview with her. I do a huge question and answer for her tomorrow. So it's going to be 5.5 hours just on inflammatory bowel disease.
Okay.
So I do a lot of teaching and a lot of lecturing around. You can find me at my website as naturopathicgastro.com.
Okay.
And I still see patients, and I also have some residents who work under me, where if people don't want to wait, they can absolutely, the residents run all of their cases through me. And so we work on the cases together, but it's a lot cheaper and it's a lot easier to get in with them.
Awesome.
Thank you
so much.
That was so fun. Thank you.